Good afternoon, everyone. Have you had happy meal for lunch? I did. I'm very happy to join this seminar as a session chair. The first speaker of this session is Dr. Kerry Courneya. I met him first. Simply to say, he is very influential in this field of exercise oncology. The title is New Evidence on the Role of Exercise as a Cancer Treatment. Please.
All right, good afternoon, everyone. It's a pleasure to be here, and I'd like to thank Professor Justin Jang for inviting me here this week and for hosting me. I've had a great week meeting with him and his students and discussing potential collaboration, so it's been a real pleasure to see all of the research that's going on here in Korea. So today I'd like to share with you some new evidence on the role of exercise as a cancer treatment. Exercise has well-established benefits related to supportive care, things like health-related fitness, symptoms, psychosocial outcomes, and quality of life. And we've heard about some of those outcomes this morning. These outcomes are very important, and in fact, they've driven the exercise guidelines. So we've made guidelines for cancer patients to exercise based on these types of outcomes. But it's also possible that exercise could act as a cancer treatment, meaning that exercise might treat the disease itself, not just the symptoms and side effects of the disease. And this, of course, would be a very important outcome for cancer patients and for oncologists, and even more likely to change clinical practice. We heard Dr. Ligabel this morning say if we can demonstrate benefits to cancer outcomes, this is even more compelling evidence for benefit. But this proposed idea that exercise might be a cancer treatment is based on preliminary evidence from animal studies and observational studies that Dr. Ligabel covered this morning, and some exploratory underpowered clinical trials. However, testing exercise as a cancer treatment is very complicated because there's an infinite number of clinical oncology settings. You all know there's 100 different cancer types, maybe 200 when you get into subtypes of cancer, and there's all sorts of treatment protocols. Over 100 different chemotherapy drugs, new immunotherapy drugs coming on the scene every day, all different types of radiation therapy. So talking about exercise as a cancer treatment is very complex and complicated with all of these different treatment protocols for different patient groups. So we thought a conceptual framework may be helpful to try and structure and organize clinical oncology settings. How can we think about clinical oncology settings from an exercise and cancer treatment perspective? Identify the critical aspects of those clinical oncology settings, and then start this systematic approach to study exercise as a cancer treatment. Because this is very new, it's very novel. We've looked at the effects of exercise on health-related fitness and patient-reported outcomes for a couple of decades, but only more recently have we started to think about exercise as a cancer treatment. So this is a paper we published just a couple of months ago. So this is my sort of thinking on this topic over the last year and ending up in this publication. My colleague here, Christopher Booth, is a medical oncologist from Kingston, Ontario, and he was very helpful in this paper. But we've titled it Exercise as Cancer Treatment and a Clinical Oncology Framework for Exercise Oncology Research. I'm going to share with that with you today just briefly, but then also talk about some of the research that's been done within this framework. So this exact framework, as we call it, exercise as cancer treatment, we use the abbreviation EXACT, is based on two key clinical oncology variables. One is the tumor disease status of the patient, and the second is the treatment status of the patient. So the first important variable is related to the tumor disease status that the patient presents with in the clinic when you're thinking about an exercise treatment intervention. And we argue there's three basic scenarios that are critical. One is the primary tumors removed. So this is a very common clinical situation. A cancer patient is diagnosed with an early stage tumor and they quickly go into surgery and they get that surgery within 1 or 2 weeks. So by the time you're approaching them in the clinic, the primary tumor's been removed. Under that clinical scenario, we're really looking at exercise to treat these micrometastases, meaning at the time the primary tumor is removed, a small number of cancer cells might have escaped the primary tumor, gotten into circulation, and then spread elsewhere and set up kind of disseminated tumor cells elsewhere in the body and started to potentially grow. So the question under this scenario is, can exercise treat these micrometastases, small numbers of cells that have escaped the primary tumor? The second scenario we sometimes see is the primary tumor is present, meaning it's not been removed yet, and surgery is not the first treatment we're giving the patient. So these are patients who might get chemotherapy or radiation therapy as neoadjuvant treatment prior to surgery. Or they may not get any treatment at all, such as prostate cancer in active surveillance. So under this scenario, the goal of exercise would be to treat the primary tumor itself and see, can we shrink that tumor? Can we slow the growth of that tumor? The third scenario, unfortunately, we have some patients that present with metastatic disease. So widespread disease, macroscopic metastases at various locations in the body. Obviously, in this scenario, it's a very different question about how exercise can treat these metastases that have already spread elsewhere. So each of these three kind of scenarios are different steps in the metastatic cascade, from the primary tumor, intravasation into the blood vessels, circulating tumor cells going through the bloodstream, extravasation at the site of these distant organs, and then beginning to grow at these foreign or distant environments. So everyone, because these are such distinct steps of the metastatic cascade, if we're thinking of exercise as a cancer treatment, those are very different functions that exercise would have to perform in order to be considered a cancer treatment. The other reason this distinction is important is because there's genetic and epigenetic differences between primary tumor cells and metastatic cancer cells. So just because exercise slows the growth of a primary tumor doesn't mean it would slow the growth of those metastatic cells, because they're oftentimes very different than what's located in the primary tumor. So we have these genetic differences and we have these different phases of the metastatic cascade, and we need to look at the role of exercise for all these different phases, and it might be very different. The other key element, though, is the treatment status of the patients. So at the time an exercise specialist might see a cancer patient in the clinic, they might be treatment naive, meaning there's been no treatments for that disease yet. And that could be for a couple of reasons. One, they could be on active surveillance and no treatment is planned. 2, it could be a delay prior to getting treatments. Or 3, there could be no real treatments available. No adjuvant treatments have been shown to be beneficial, and so no further treatments are given to the patient. Of course, the patient can also be actively treated. And we heard about this from Dr. Ligabel. The focus this morning was exercise during cancer treatment, chemotherapy, radiation therapy. So that's also a critical phase. And then, of course, we can have patients after treatment. So patients who have been previously treated for their cancer. Why is that important? These treatments alter the genetics of the cancer cells and the location of any remaining cancer cells. So these cancer cells can produce newly acquired mutations after being treated. And these may alter the subsequent effects of exercise. So just because exercise slows the growth of some cancer cells that have not been treated, you treat those cancer cells with chemotherapy, it could be very different now. Exercise may not slow the growth of those cancer cells. And it can even happen vice versa, meaning exercise might not be effective before chemotherapy because of whatever mutations the cancer cells have, but after chemotherapy, the chemotherapy might sensitize these cells or cause different mutations that are now vulnerable to exercise. So you can see how these treatments may alter the effectiveness of exercise as a cancer treatment. So we have to take that into account. Treatment sequence is critical. The order that we treat patients with is very important. This is the whole expansion of this area of neoadjuvant treatment. In the early days, everybody with a newly diagnosed cancer went straight to surgery, and then we'd follow up with additional adjuvant treatments. Now there's a lot of neoadjuvant treatments, sometimes chemotherapy before surgery, sometimes immunotherapies, because they all have different effects. So how we time these treatments and how we combine these treatments is important. And we as exercise scientists need to think the same way. We have to think about, how do we sequence exercise in these treatments? Should it be before chemo, during chemo, after chemo? Same with radiation therapy, same with immunotherapy. And so these are critically important aspects when thinking about exercise from a cancer treatment perspective. So those two kind of key variables, the clinical oncology variables and the treatment status variables, result in 9 distinct clinical oncology scenarios. I guess I could call them 9 generic clinical oncology scenarios as well. So you can see, if the primary tumor's been removed and the patient's not being treated yet, you know, what we're dealing with from an exercise perspective is trying to treat treatment-naive micrometastases. If we're intervening during active treatment, we're trying to see, will exercise help treat actively treated micrometastases? Under primary tumor growth, if nothing's been being given to treat the tumor, again, exercise is trying to, oh, was that me? No. Exercise is trying to treat treatment-naive primary tumors. So these are what I would call the 9 key scenarios that we could look at from an exercise perspective, even though each of these scenarios has all different types of cancer and all different treatments, right? So, but these are kind of the generic ones we could look at. And so what I'll share with you is some of the research we've done in each of these kind of clinical oncology scenarios to see how we approach them. Just talking generally about the mechanisms. I won't spend too much time on this during my talk, but there are well-known mechanisms for how exercise might influence tumor growth, spread, and dissemination of these tumor cells. I kind of think of them in 2 categories, intratumoral and systemic. So intratumoral meaning somehow exercise has to get inside the tumor and attack the cancer cells inside the tumor. Systemic meaning throughout the body, where there's small numbers of cancer cells that might be traveling around the body, and exercise would have to treat those. We can also think of them as the biological factors and this mechanical effect. Most of the focus has been on biological mechanisms, insulin-like growth factor, anti-inflammatory mechanisms, immune system function, and many other biological, reactive oxygen species, and so on. So that's been a focus. But mechanical, this hemodynamics is getting a lot of attention. And this is the idea of shear stress, that when you exercise, not only does it have biological effects, it changes the speed with which blood flows, and it changes the location of where the blood flows, right? You've all learned about shunting during exercise, where certain organs constrict and we don't have blood flow to those organs, and then the working muscles dilate, and we include a lot of additional blood for those working muscles. So this goes on during an exercise session, and you can imagine how important it is about how fast the blood flowing and where it's flowing. And there's some evidence now suggesting that this hemodynamic shear stress can help kill cancer cells that are circulating within the body, and also influence the tumor itself in terms of blood flow to the tumor and oxygenation and so on. And I'll talk a little bit more about that as we go through it. But these are kind of the general mechanisms we talk about. So let's start with this scenario of a treatment-naive primary tumor. So the patient's got a primary tumor, but not received any treatment yet. This is where most of the animal research has gone on, and really not much beyond kind of the animal research. So let me summarize that research for you. So this is a systematic review looking at the impact of physical exercise on the growth and progression of cancer in rodents. So these are all rodent or mouse models. And they did a systematic review and meta-analysis. So in these studies, we can take a mouse, implant cancer cells, and then put them in an exercise group versus a non-exercise group, and then we can compare how fast these tumors grow, just like they would a drug if they were testing a drug in mouse models. And this is the general finding that we see across this systematic review and all the studies that have been done. The general pattern of the finding is that tumors and mice that receive exercise, the tumors grow more slowly, right, suggesting some sort of effect of exercise on how these primary tumors are growing. But you'll notice a couple things here and across these studies. Exercise almost never reverses the growth of a tumor, and it almost never eliminates a tumor. Typically, all it does is slow the growth. So it's not going to be a cure by itself. It's not going to eliminate the tumor by itself, but it can slow the growth, suggesting that there's some anti-cancer activity. The other key point is this is typically what happens. This is not always what happens. So in about 2/3 of the studies, we see exercise slowing the growth of the tumor. But in about 1/4 of the studies, there's no difference whatsoever. Exercise has no impact on the growth of the tumor. And unfortunately, in about 9 or 10% of the studies, the tumors grow and spread more quickly in the exercise animals. So this is where we have to be a little bit cautious to say, oh yeah, exercise is good for every type of tumor, every type of cancer that you have. Some of these studies show tumors growing more quickly in the mice that get exercise than not. The last point to make about this scenario is, of course, this is mice. And mice to humans is not necessarily a one-to-one generalization. So very little research has gone on in humans. And in the past, we didn't have a lot of scenarios to look at exercise and a primary tumor that's untreated, right? Typically, you have a primary tumor, you're rushed into surgery or rushed onto treatment. But one of these scenarios that's arisen is prostate cancer. And the treatment or non-treatment, if you want to call it that, is called active surveillance. So these men are diagnosed with small tumors. They're not very aggressive. They're low-grade tumors. And so we say we're not going to treat them, but they still have a prostate cancer there. And so this is a study that was done by my former PhD student. Some of you may know Dongwoo Kang, who did his training with Justin here during his master's, came to Edmonton, Alberta for his PhD, and he's now at Dana-Farber Cancer Center for his postdoctoral fellow. And Dongwoo's idea was to look at exercise in these prostate cancer patients who are not receiving any treatments for their disease. And we called it the ERASE trial. We screened a lot of men to check them for eligibility and living close by. And ultimately, we ended up randomizing 52 prostate cancer patients on active surveillance. Dongwoo was able to achieve very high adherence rates, well over 90%. And good follow-up data on these prostate cancer patients. This is the exercise program he developed, a high-intensity interval training. So after a warm-up and cool down, a couple minutes of fairly high-intensity exercise at over 90%, and then more light-intensity intervals at around 40%. And you can see somewhere about 8 different intervals were tested. So it was a fairly vigorous and fairly intense program that we had these guys do. And he did blood samples at baseline, and then the 12-week supervised exercise intervention, he did blood samples afterwards and measured a bunch of other outcomes as well, fitness, quality of life, and so on. Fitness went up in the group that received the high interval training program, and it went down slightly in the usual care group. So we saw a significant effect on peak oxygen consumption of about 1.4 mils. But the more important and critical findings was the effects that we showed on PSA levels. So this is prostate-specific antigen, and it can be an indicator of the activity of cancer in the prostate. And you can see here there's a significant reduction in PSA levels in the exercise group compared to the usual care group. And also a significant reduction in the PSA velocity, so how rapidly it's changing over time. And no change in testosterone levels, and a trend towards a change in PSA doubling time. So all indicators that exercise might be having some sort of effect on the prostate cancer. What Dongwoo also did is take in vitro prostate cancer cells and expose them to the serum of the men who exercised versus the serum of the men who didn't exercise, and looked at in vitro what happened to these prostate cancer cells. And again, a significant effect. The cells in the men who had exercised prostate cancer cells grew far more slowly compared to the change in the usual care group, suggesting that high-intensity exercise training might be slowing the growth of these prostate cancer cells. And this is really one of the first studies in humans to try and look at this issue of whether exercise might be slowing the growth of an untreated primary tumor. So this study received a lot of attention from the media in North America and a lot of attention from urologists. They are very excited about the possibility of using exercise to help these men with prostate cancer. And I'm not presenting any of the data here on the psychological outcomes, but we showed significant improvements in fear of cancer progression, in anxiety, in self-esteem, and other important outcomes. This is just focusing on the cancer progression. So if this were true, if working out can slow prostate cancer progression, this would be a very exciting finding, and you'd see a lot of men very motivated to exercise when they go on to this active surveillance scenario. So what about actively treated primary tumors? That scenario with prostate cancer is still fairly rare. There's not a lot of cancers that we diagnose and then say, oh, we're not going to treat them for a while. Most will go on to be actively treated. And so people have kind of criticized some of these preclinical mouse models to say, looking at untreated primary tumors is not super relevant from a clinical perspective. And so we've seen a shift in an interest to say, what about the effects of exercise on actively treated primary tumors? And there's a growing interest in these preclinical animal studies. So we did a systematic review on this issue of looking at the effects of exercise on cancer treatment efficacy. So if you exercise at the same time you're getting the cancer treatment, does it alter the efficacy of that cancer treatment? And this is a systematic review led by Lin Yang, who's a research scientist at Alberta Health Services. So we reviewed the preclinical and the clinical studies. We found 6 preclinical studies at the time, and there's more because this is a growing area of interest. But we found 8 rodent models using breast cancer cells, melanoma cancer cells, Ewing sarcoma, and so on. And 7 of these studies tested a single agent chemotherapy, and 1 even tested tamoxifen. We now have some studies testing immunotherapies in these mouse models along with exercise. The great thing, of course, about these mouse studies is you can do these full factorial designs. So we can randomize these mice to get nothing. They can get the treatment, so the chemotherapy alone. They can get exercise alone, or they can get the combination of the treatment plus exercise. And then we can look at how these treatments interact. What most of these studies show, very exciting finding, is that exercise improves drug efficacy. So the animals that exercise get better effects from these chemotherapy treatments than the ones that don't. So here's a typical study, the way it's done. So you implant the cancers into the mice, but rather than randomizing them to exercise and control, you also have a drug group. In this case, it was gemcitabine, one of the common chemotherapies, and gemcitabine plus exercise. And look what happens in this pancreatic cell line. Exercise here in the green has no effect whatsoever. So remember, I talked a quarter of the studies show nothing. So this is an example here. Exercise alone does nothing. The chemotherapy, gemcitabine, as you would expect, slows the growth of the tumor. But look what happens when you have gemcitabine combined with exercise. It's significantly slower in terms of the growth, suggesting that there's some interaction between exercise and this chemotherapy, making it more effective. So what's the mechanism for that? They actually looked at the key mechanism, and the key mechanism is thought to be tumor vasculature. That exercise can alter the tumor vasculature, creating more blood vessels, and it can also open those blood vessels more. So then you get better perfusion of the tumor from exercise, and that leads to greater drug delivery. Right? Many of these tumors are poorly vascularized, and the drugs can't get into those tumors to have any effect. And exercise, and we think the mechanism, as I mentioned, is shear stress, the push of blood into the tumor. Because during exercise, the rest of your body might constrict, vasoconstrict, but tumors don't have that capacity. They remain open. And so they get a lot of blood pumped into them during an exercise session, and this causes those vessels to grow, angiogenesis and so on. And so you can see here they showed more vessels in the tumors of the mice that exercised and bigger lumens, so bigger openings. So this is the control here. You can see not much in terms of openings. Look at how large these tumor vessel openings are here now. So these are your blood vessels open. So the blood is now being pumped into these tumors far more in the exercising animals. And when you give drug along with it, you can see this combination effect. So this is a very exciting finding that's led to this idea, well, maybe if we're looking at exercise as a cancer treatment, we really want to combine it. Remember, I talked about the sequencing of these treatments. How should we combine them together? Might be far more bang for our buck than just exercise alone. Now, the thing I should mention then as well is not only do you get better drug delivery, so chemotherapy works better, you get better oxygenation of the tumor. And oxygenation is critical for radiation therapy. Many of these tumors are hypoxic and they don't respond well to radiation therapy. If you can increase the oxygenation of the tumor, and because you increase the blood flow of the tumor, you get better oxygenation. So that would lead us to theorize that not only should you get better effects from chemotherapy, you might also get better effects from radiation therapy. So based on that idea, this is a trial led by a former PhD student, Andrea Morielli, who's now a postdoctoral fellow at Alberta Health Services. And she wanted to look at this issue in rectal cancer patients. And it's really a perfect group to look at this because they get neoadjuvant treatment prior to surgery. So this is the standard treatment kind of for these locally advanced rectal cancers. You get, it's not removed surgically, so you still have the tumor there, but you get 5 to 6 weeks of combined chemoradiation therapy to try and shrink the tumor to make the surgery more effective, less invasive, and so on. And then you get a break for about 6 to 8 weeks because the tumor keeps shrinking. So we're downstaging and trying to shrink the tumor. And then they go on to surgery, and we can see what happens at that point. Obviously, the goal in this scenario is what we call a complete response. So we want the tumor to be completely gone. And then under that scenario, they have the best chance at a cure and survival. And more recently, people are saying, well, maybe you don't even need the surgery under that scenario if you get a complete response. So we didn't, afterwards they get more treatments, but we didn't look at that. So she did a randomized trial where they were randomized to HIT exercise or usual care during this 5 to 6 weeks of chemoradiation, the break, and then we looked at surgery and we looked at what kind of response from the tumor happened. So this was a relatively small study. We ended up randomizing 36 patients, so it's a very small kind of pilot study, 18 patients in each group. They did supervised HIT training during chemoradiation therapy and then unsupervised home-based exercise afterwards. And similar to Dongwoo Kang's study, she did a HIT training protocol. So you can see again, 2 minutes of high intensity exercise, 2 minutes of lower intensity, 5-minute warm up and cool down. Total duration of about 28 to 40 minutes of exercise training. And this is based on a pilot study that she did during master's thesis. So the tumor is getting treated with chemoradiation therapy, and now we can look at, does exercise help or hurt or have no effects? And much to our pleasant surprise, despite this small sample, we showed a significant effect, statistically significant effect. In the exercise group, 10 out of 18 or 55% of the patients had a complete pathologic response, meaning that at surgery, they can go in and look and test if there's any cancer cells there. Compared to the usual care group, only exactly 3 out of 17 or about 15% had a complete response. So 3 times as many patients in the exercise group compared to the usual care group. These are obviously very small numbers, but it shows you things are happening in the right direction in terms of the effect. So if you exercise while you get this chemoradiation therapy, you might have a higher chance of a complete response, better chance at cure, and a better chance maybe at avoiding surgery. So again, a very provocative finding, probably based on those mechanisms we talked about in terms of increased perfusion to the tumor, improved vasculature to the tumor, and so on. So again, you can imagine these studies get a lot of media attention and a lot of hype. You know, when you look at health-related fitness or patient-reported outcomes, sometimes the media is interested. But when you're looking at the tumors themselves, this can generate a lot of interest from cancer patients, from the GI oncologists, and from the media. So here you can see a very provocative title: Patients with rectal cancer who exercise while receiving radiation therapy more likely to have tumors disappear. So from a cancer patient perspective, you'd be very excited to see these types of findings. Treatment, so let's move to another scenario which I talked about earlier, treatment-naive micrometastases. So this is the more common scenario where the small tumor is surgically removed. And if that tumor is surgically removed, the only thing that can be left is maybe some micrometastases, small number of cells that have escaped the primary tumor and have now lodged at different points in the body. What can exercise do in that scenario? So we don't have any experimental data, but this is an observational study looking at physical activity and survival in endometrial cancer survivors. When I visited here 4.5 years ago, I presented this study as ongoing at the time and said, okay, you know, we don't have the results yet, but this is the study that's ongoing. So we now have the results, and we're able actually to publish these in the Journal of Clinical Oncology, looking at this association. So why am I reporting this one here? Well, if you look at the treatments, so these endometrial cancer patients, if you look at the treatments, you can see 98% of them get surgery. So almost all of them get surgery. Very few get chemo or radiation therapy. 6% got chemo, 30% got radiation therapy. So that means the vast majority of these patients have treatment-naive micrometastases. They only get the surgery, and then they're off on their own with no further treatments. So this is that clinical scenario I just talked about of treatment-naive micrometastases. And what we found is physical activity was associated highly significantly with improvements in disease-free survival and overall survival in these patients, suggesting the possibility that if you have untreated micrometastases, exercise might be able to track down and kill those cancer cells through mechanisms like insulin, IGF, immunosurveillance, which I think is one of the critical ones, anti-inflammation, and other growth factors. What about actively treated micrometastases? Again, this is the more common scenario. Rarely do we do surgery and nothing afterwards. Typically, we'll give chemotherapy, radiation, and so on. So now we're into this common scenario where you've had the tumor surgically removed, but we are going to treat these known or suspected micrometastases. So this is a trial we did a few years back, and it was really, I think, in some ways ahead of its time because we didn't have a good explanation for this finding at the time, but we do now with this newer mechanistic research. This is called the START trial, and it was a randomized trial comparing aerobic exercise training to resistance exercise training to usual care in 242 breast cancer patients, all on chemotherapy. So the exercise was done during chemotherapy. They did supervised exercise 3 times per week for moderate to vigorous intensity, progressed them over the course of the chemo. Same with the strength training program, 3 times per week, a good quality strength training program. Usual care group had no structured exercise. We got pretty good adherence of around 70%, given some of the challenges and difficulty of chemotherapy. So we looked at quality of life and symptoms and fitness outcomes and so on. But then the medical oncologist on this study, John Mackey, said, oh, why don't you follow them up to see what happens to the long-term outcomes? What happens to their risk of recurrence? And keep in mind, the only difference was the exercise done during the chemotherapy. After the chemotherapy, they were free to all do whatever exercise they wanted to. And so they all crossed over, and we gave the usual care group exercise program and stuff as well. So when we followed up 6 months later, they were all doing the same amount of exercise. There was no difference. So the only difference is whether or not they exercised during their chemotherapy. And when we followed them up 8 years later, so this is 8-year median disease-free survival was 82.7% for the exercise groups combined, because it was a relatively small sample. We combined them, but there was no difference between aerobic and strength, versus 75.6% for usual care. So this is a 7% absolute difference in disease-free survival depending on whether you exercise during chemotherapy or not. If this was a chemotherapy drug, it would be put into practice and it would be funded by all the insurance agencies. Now, the sample's not large enough. It's not a significant finding, so we're not sure if it's a reliable finding, but the hazard ratio of 0.68. So the exercise groups had a 32% lower chance of having a disease-free survival event, which is a recurrence, a second cancer, death from breast cancer, or death from any cause during follow-up. And so these mechanisms, then here we're talking about not exercise having effects on the micrometastases like the endometrial study I just showed you. Now it's working with chemotherapy. So how does it work with chemotherapy? Well, some of the evidence suggests, again, a shear stress mechanism. When blood is pumping into these areas, it damages cancer cells and it makes them more susceptible to chemotherapy. And this has been shown in a in vitro model where they spin these cancer cells through various tubes and they can see how many die based on the shear stress. And then they mix in chemotherapy and spin them through the tubes, and they can see that at rest, the chemotherapy only kills a certain number of those cancer cells, but when you're spinning those cancer cells and give chemotherapy, a lot more die. And there's mechanisms related to cellular damage and structural damage to these cells. So we now have a potential mechanism for how exercise might help chemotherapy treat micrometastases, in this case, not a primary tumor. Previously treated micrometastases, this is a very common scenario, right? You go in, you get your surgery, you get your adjuvant chemotherapy, your adjuvant radiation therapy, and then you're done. So in this scenario, we're looking at, can exercise treat micrometastases that have been previously treated but are still lingering behind, so they didn't get a complete response to the treatment? This is a very common scenario because oftentimes the exercise interventions we do are after treatment. Right? We want to wait till the patients are feeling better and they've recovered from chemotherapy, and patients themselves sometimes are more interested in exercise after they've completed these adjuvant therapies. So this is a very important clinical scenario. We don't have the research on this right now, but this is where the challenge trial is looking at this issue. Dr. Ligabel talked about that trial this morning. But what we're recruiting here is stage 3 colon cancer patients who have completed chemotherapy 2 to 6 months after chemotherapy. So it's exactly in this kind of survivorship phase and these previously treated micrometastases. So here we're going to look at whether exercise acts kind of like a maintenance therapy after adjuvant therapy and can further reduce the risk of the disease coming back. We're recruiting 962 patients. We've randomized about 850. So if Justin has me back in about 4 years, we may have the results of this trial for you to share. Actively treated metastatic disease. Again, another very important issue. There's many patients with metastatic disease. We now have lots of treatments for them, especially in breast, but also testicular and other lymphomas and so on. So we do treat metastatic disease, and we can improve survival substantially, even though oftentimes we don't cure it. So this was a study we called the Healthy Exercise for Lymphoma Patients trial. So this compared aerobic exercise to no exercise in lymphoma patients, either on chemo. So 54 of these patients were on chemo, 68 were not on chemo. 12-week supervised exercise training. We were mostly interested in fitness, symptoms, quality of life, but we did assess treatment response in those 54 patients that were on chemotherapy to look at how did they respond to the chemotherapy in terms of the tumor, not just quality of life and fitness and so on. So again, not a significant finding, but in the right direction. So in the exercise group, about 46% of patients had a complete response to the chemotherapy. In the group that didn't exercise, about 30% had a complete response. Not a significant finding here, p equals 0.24, but in that same direction of suggesting if you exercise while getting chemotherapy, in this case, for metastatic lymphoma. So lymphoma is spread throughout the body, different tumors and clumps around there. And again, suggesting that exercise might be improving the delivery of the chemotherapy to the tumors, resulting in more complete response in those patients that exercise compared to those who didn't exercise. So this study also got some media attention, and I think they summarized it very nicely. They said exercise is good medicine for lymphoma patients. A healthy dose of exercise is good medicine, even for lymphoma patients receiving chemotherapy. And in addition to quality of life benefits and symptom and side effect improvements, they may get improvements to the disease outcomes themselves. So to summarize, most of the exercise oncology research has focused on supportive care outcomes. And I do want to emphasize the point, these are important outcomes. I'm not trying to say these are not important. These are very important outcomes to patients. Quality of life is very important. Managing side effects like fatigue and diarrhea and bowel dysfunction and shoulder dysfunction are very important for these patients. But in addition to those outcomes, we're seeing an interest in looking at exercise as a cancer treatment. Preliminary research suggests that exercise may treat primary tumors, micrometastases, and metastatic disease through various biological and mechanical effects. And if we're able to show exercise is a cancer treatment in some of these scenarios, I think that will have a big impact on clinical practice and a big impact on our patients. I'd like to end by acknowledging many colleagues, students, staff, and study participants who have contributed to this research, and also the support I received from the Canada Research Chairs Program, the Canadian Institutes of Health Research Foundation Grant, and the Apple Fitness Store that supplied equipment to my fitness center. Thank you very much for your time.